Can you all hear me? Yes, good. Okay, sorry, I'm a few minutes late. So this may seem simple, but hopefully you may learn something from this. And there will be a little bit interactive. So there'll be some case scenarios and some quizzes. So I appreciate if you want to participate. So when you enter, you can put your hand up. You can speak out or you can type. But if you want to type, please send it to everyone so that everyone can hear what you're trying. Your question is. Okay. So bear with me. So some of them might be very simple, but hopefully there'll be something that's new that you might learn. Okay. So the objective in chest pain is, usually in an acute setting, patient comes to you in a usually emergency or scenario, then you have to be able to assess this patient quite quickly. And then very quickly trying to come down to the likely differential diagnoses. And then the next step, what are you going to do? To confirm or exclude differential diagnosis and therefore start treatment. I think at your stage, I think the important thing is a good practice. Always bear in mind, but not missing the life-threatening causes that you should miss. So in every patient, even though you think it's really ACS, you should really think of other things, because if you don't think of that, then you sort of, you never think of it. Okay, so you always have to bear in mind what you shouldn't miss. So the differential diagnosis for chest pain is quite wide. I'm not going to go through all of them. You can see here, wow, it could be cardiac, and cardiac could be ischemia or non-ischemic cardiac or pulmonary, pleural, aortic, chest wall, esophagus. Everything can cause sort of pain in this region. So, but I think if you're a good clinician, after a few questions and sort of you can narrow it down fairly quickly, but sometimes it can be difficult. So what are the 5, causes of chest pain that can kill that you shouldn't miss? Anybody? You want to get you started thinking? Anyone? Because I don't want to have a monologue for for an hour. So it'll be good. So I can move on. Okay, good. MY, alkaline infarction. Obviously, that's the most first thing comes to mind. PE, yes, that's good, because a lot of people don't think about PE as causing chest pain. Aortic dissection, yes, aortic dissection. Okay, got 3. Okay, 2 a little bit tricky, but might think. Pneumothorax. So it doesn't be tension, but pneumothorax itself will cause pain. So tension is just life, more extreme sort of pneumothorax, but pneumothorax can cause pain. Esophagus rupture, yeah. So this is very rare, but you have to think about it sometimes. So these are the chest pain that can kill. Okay, obviously tamponade myocarditis, tamponade is a complication of a problem, for example, like dissection or whatever. And myocarditis can be severe, but usually you cannot often tell just initially. So key things, I think acute coronary syndrome is biopulmonary embolism. So drum into yourself, think about it every time you see someone with chest pain, even vaguely, even if fleetingly thought about it. Otherwise, you may miss because they can be very typical. So but however, overall in the whole scheme of things, the most common chest pains are usually benign, and most of these are sort of non-specific, or it's called musculoskeletal, esophagitis, bronchitis, and the rest. We don't know what's going on, but it's not acute, so we can work out later. I think your approach is make sure you don't miss the things that are going to kill you first, and then you can work out the rest later. So the next day. So, but this is just a scheme of things. Obviously, depending on what population you see, if you look at the most common causes, you can see here by far at all age groups, then most of it is not specific chest pain. So most of it actually be more real world. If you go to see go to 10C, go to coronary care, yes, every chest pain is some sort of severe MI or anything. But if you in perspective, you go to emergency, you're going to see a whole lot more non-specific chest pain before you see someone severe. But also between the age group, you can see that in terms of, say, for example, coronary problem, then obviously with increasing age is more likely, but still by far, not specific, the scheme of things is more common. So that is more in perspective that not everybody you see chest pain has got myocardial ischemia, but it's something you need to exclude. And there's things that make you more suspicious, and this comes with your history taking and words that's going to prompt you. Obviously it's not a hard and fast rule, but the more, so these sort of features will put you more on a probability scale. Okay, sometimes you don't know. But if you're thinking it's more the typical central squeezing chest pain, impending sense of doom, is more likely ischemic, but it's not absolute. Most other patients may have none of those. Okay, but if it's more of the sharp, fleeting, second sort of stabbing sort of thing and sort of go everywhere, then it's less likely. So I think it comes with experience when you see a lot more patients with chest pain and you get a more feel, and that comes with really your clinical suspicions and feel. I'm not going to go through all this, but you can have the slides. But there are things which may prompt you one way or the other. Okay, so they are things that you see more and more chest pain, then you start getting used to, get more familiar with features that suggest it one way or the other. And these are the things you would ask. You don't have to ask for all of them, because sometimes it's pretty obvious. The pain is most likely cardiac, and ischemic. Then you don't need to ask every single question. These are questions when you're not so sure. Then you will add. They'll help you discern. But once you get the when you are fairly sure, then you can move on. Okay, so in terms of ACS, for example, and it's a huge spectrum of symptoms that may say, for even the location can be very variable. Not everyone's going to come in with impending chest pain radiating to the arm, but people with just the neck pain, jaw pain, so even right arm, left arm, even epigastric pain, and both sides. So it can be very typical. Okay, and then also they can be associated with a variety of other symptoms, nausea and vomiting, cold sweat, short of breath, dizzy, a lot of things that can be a whole spectrum. So there's no specific, one or two feature which makes it more definitely ischemic. And this is I'll just highlight one thing. It's a common pitfall that a lot of people fall into is about the fact that the pain is relief by GTN, because you ask the patient, "Oh, what happened?" I took some GTN in my tongue, and then relief, and you're sort of assuming if you relieve a GTN, it must be ischemic or more likely ischemic. But I think you need to quantify that. Firstly, all of the patients will have a GTN that's been long expired, and obviously whatever is taking is not active. Okay, so sometimes patients rarely use GTN and they just found one at home. And how long is it? It's been expired for like 2 years. And you're going to say, hey, this is not due to the GTN. And then, because also the GTN can also, it can relieve both ischemic and also esophageal spasm. So you're going to be mindful that, GTN is not specific for ischemic chest pain. And also it's very important to quantify how quickly does the pain improve after the GTN. Because you put that thing under the tongue, GTN should begin effect within minutes. Okay, but sometimes you ask the patient, "Oh, you took GTN. When did it start relief?" "Oh, half an hour later, it went away." Okay, so by definition, the pain wasn't relieved by GTN. The pain was relieved by itself. Okay, but it's often recorded that pain relief by GTN. I think you have to be more to quantify that and make sure that pain is related to the GTN. So it's a common pitfall that a lot of people assume because it took GTN improved, then it must be or highly likely ischemic. But you just need to ask a few more questions. And also beware that women and elderly often present with more atypical symptoms. They less frequently with a typical chest pain, but they often present with short of breath, nausea, vomiting, lightheaded, vague abdominal pain if they're elderly. Okay, and this is why often they present late or they diagnose late and also have a worse prognosis because they often confirm diagnosed later. And as someone has actually done a study and has you believe or not that women has a higher pain threshold than men. Men are more squeamish, and so women are able to tolerate pain, but more so they come later. So this is one theory, but it's also important in women and elderly is to not just at the pain description, but overall assessing the cardiovascular risk profile. Okay, the past history, family history, do they have diabetes, smoking, and all that, which put them more in a higher category and less reliant on the symptom itself, because the symptom can be less specific. Okay, especially women and elderly. And physical examination, again, I'm not going through every single one, but you can look through. And there are things that you can find in physical examination and things that is not going to helpful. For example, ACS is not anything particular that will give you specifically that an examination ACS. You may find that complication ACS, for example, a patient has a heart failure as a result of ACS, or has valvular papillary rupture, or VS for free or rupture as a result of your ACS. But ACS itself may not be very specific signs. Also, in pulmonary embolism, there may not be specific signs for it. You may have pruritic chest pain, but it may not, or just dyspnea. The dyspnea could be a lot of things. Maybe only aortic dissection and pneumothorax you can probably diagnose clinically. Okay, so pneumothorax is easy and clinically, and also with dissection, again, is not 100%, but you may find pulse differentiation. Patient has some sort of marphenol appearance, and then but in a clinical examination you may not get much more. It may be you have a esophageal rupture, you have superficial emphysema, but overall, you may not have find a lot of specific things for the diagnosis. You can see here down below, some of them happen, can appear for different diagnoses. So be aware that the physical examination is important, but often may not be as revealing as the history itself. So after you take the clinical examination of history, and you have some sort of vague idea of what's going on, but what are the 3 bedside tests you should consider in almost everyone with chest pain? Anybody? Because sort of periodically I ask questions to make sure we are still here. Otherwise, we'll be stuck. It's like a checkpoint. For sure, yeah, ECG. So definitely get an ECG. This is one of those guidelines. Even with chest pain, it's vaguely ischemic. You should get a chest ECG within 5 to 10 minutes and interpret it. So ECG is important. Yeah, bedside echo, that will not routinely we do, but it's going to become more and more useful with your training now. Not in my days, but now with handheld echoes, yes, definitely chest X-ray. Yeah, one more. One more. You may not think of it, but we can do it bedside. Anybody? No? I think of? Okay. Okay, so ECG definitely, but you always, if it's available, always ask for an OCG to compare, because whatever you're seeing could be old changes. Okay, so definitely ask ECG and try to look for an old one to compare. Yes, get a chest X-ray, because chest X-ray will give you some of the diagnoses. And one that people don't think about is you can get a point of care testing is available in most places. You can get a troponin in almost within 10, 15 minutes. You can just take the blood, it's a machine, and then you can just get, and that could really help you in other things. So I would consider that as, almost put it up front as more like a bedside test than so you can get a troponin in fairly quickly. And yes, handheld echoes is going to become almost routine. Everybody of you is not going to carry one of these things around you. Okay, because it can give a lot of things. Doesn't replace an echocardiogram, but is a portable, what we call an ultrasound, that can give you a few things. LV ejection fraction, look for any regional abnormalities suggestive of ischemia. You can look for LV ratio, suggestion of massive pulmonary embolism. You can look at effusion, tamponade, pleural effusion if you're skillful enough, aortic dissection, some, not all of them, and valvular regurgitation. So it's very helpful. We really augment what we can do with just history and examination. So, you guys getting training in handheld echo in the curriculum? You're getting, is it optional, routine? You get exposure to it? You guys getting it? Is Professor Lee giving some sort of a lecture or specific on this, or you guys going to get some hand up slightly in SLC? I think this will not real since SLC return Zoom. This is something that is a very good skill to have, and then it doesn't take long. And I have done a little study with some little student that you guys can learn it within a few sessions. Not, expert, but at least the major things, what I've listed here. You can, all of you can do it very quickly. So this is something that, should learn, because it's going to become an extension of your stethoscope. So let's be more exciting than just giving your facts. Let's do some thinking, get you involved. So we have case one. So you're the houseman, okay? And then in the middle of the night, 3 a.m., and you've been called by the nurse because Mr. Z has developed chest pain in the ward. And you arrived and you look at the notes, and then Ms. Z has 65, female, past history of coronary disease, and has a PCI MI some years ago, and has a COPD, and it's got right hip surgery 3 weeks ago. And it's now admitted for exacerbation of COPD. What are you going to do next? What are you thinking? At least giving that background. What are the things you sort of flashes through your mind? Thinking from things that are going to kill you. What are things that you're going to thinking of? Sort of ranking it. So not just randomly just list the same 5 things, but you want to able to rank it in order of likelihood. All right. So although you think about all 5 different causes of life-threatening diseases, but you shouldn't give everybody the same ranking. You should think of everyone based on the history, how to rank, was high, was medium, was low, and then you work through that. Right. Okay. So based on what I've given you, what will be high up? Am I a higher rank? Okay, fine. So, PE, because of hip surgery 3 weeks ago, and she's been in bed, and then coronary disease, she had an MI before, so you could have another one after surgery, could precipitate it. So, good. So, good. Start thinking. Other less likely. Good. So, you're thinking, and you're putting it in order, and you're sort of putting it in perspective, and start incorporating the history into your differential diagnosis. Okay, it's not just ranking everyone the same. Based on the story, then I think MI, PE, lower down pneumothorax, and you go through what you find. So you obviously, if you see any patient, you want to make sure he's stable and stable. So how urgently you rush through things. Okay, so you perform your focus history examination as like before. You look at ECG, and then and if you're in doubt, call help. If you're a houseman not familiar, call your senior. Okay, so in real life, you will look through the chart, the CMS, all right, look for any clues. But beware, there are errors in CMS. It's not always right. I think you always trust yourself. And sometimes, it could be biased, it could be subjective there. But, in real life, we do look at CMS, but, if you're, you're going to don't rely everything on the CMS, okay? So after you arrive, patient feels better now with some paracetamol, but suddenly develop left-sided chest pain again. Now it's quite severe and is worse with breathing, and is not quite like her prior MI. Afebrile, heart rate is a bit fast, 120, blood pressure is borderline, 110/70, respiratory rate is a bit high, ultraset is, dropped a bit. It was 95 before, and 4 liters now. Examination, patient looks distressed, accessory muscle, echo entry, no craps, do heart sound, and no demol calf tenderness. So does this help you with your ranking now? Like you put MI, PE, based, and then maybe pneumothorax based on the story, but now with more information of physical examination, did you reorder your ranking? Are you able to rank it more, which is going to be higher now? So this is how we work. As we get assimilate more and more information, then we keep adjusting our differential and our order. All right, based on more information you get, you become more maybe more clear what the temperature. So in now, do you think it's the same? Which will be the highest right now? Do you think? And what make you think the others are less likely? Your orders changed? Will you put anything a bit more less likely? Are you going to come down to even more narrow? Maybe. Okay, you can say, let's say, PE to the chest pain. And what else? Apart that give you more clues. Apart from the what else? You're looking at other things that will give you. Try to extract as much information as you can. All right. So okay, good. So entry is equal, so not more right. So at least we'll throw that out. Not so less likely. So it's short of breath. but no crackles, E entries, and ultraset drops. So now it's down to MI or PE. I'm not saying you can definitely tell the difference, but now with information, were you leaning more towards MI or PE? Or you can't tell. You can't extract any more information. Okay, so I mean, firstly, there's no crackles, so it's unlikely there's a acute heart failure. All right, so if you think is the ultraset drops, it will require more oxygen. Okay, so the hypothesis, if you have MI itself, not necessarily doesn't do that. We only do it if, for example, it causes heart dysfunction. So it's got no heart failure, so it's unlikely this single drop of ultrasaturation to do that. So no cuff damage means it doesn't mean much. It means there's probably not likely a DVT in the cuff, but nothing you can exclude pulmonary embolism. So it's also short of breath, desaturates, tachycardic, BP low. So it's not specific, but if you give an MI or PE, then I'll probably put PE high or equal as high. So if on my differential, okay. So next is you'll get. And also, the lab comes back quickly as troponin of 40. Doesn't help you now. Normal is 0.04. While you're doing all this, we've got a bedside troponin for you. Does it make it more likely to P or ischemia, or could be both? Yes, both can raise. So troponin is very sensitive for MI, but it's not always only for MI. So in this setting, if you're considering PE, then troponin raise could be PE. And also, if your troponin rise with PE, you're looking at a very quite high risk in massive PE, and it seems to fit the picture. Desaturation, tachycardia, boiling blood pressure, troponin. So whatever it is something that's serious, ACS or PE. So what's the next step? Now I've done that. Is exactly you've got your investigation. Anything in chest X-ray? Helpful? Non-helpful? Helpful? Unhelpful? No. You can't really see what very well. So at least I can tell you can look for it's it's no pneumothorax. Chest is fairly clear, so it's not heart failure. And then you may nothing. So it doesn't helpful. So now it's ECG. So what do you see? And now what is the diagnosis? No old ECG. Oh, you haven't got old ECG. Or give you an old ECG look completely normal. This is. What do you see here are new? What are you seeing? And are you helpful? So sometimes ECG can be difficult to interpret, but once you have a fair idea of what you're looking for based on your differential diagnosis, therefore ECG is more targeted. So if you're considering, for example, MI, ACS, and PE, then you look for things that will support either one of them. Okay, so what do you see? Okay, so is this S1Q3T3? You tell me, yes. Yeah, S1 is okay. So what else are you seeing apart from that? Okay, that is you're thinking PE, but what other changes ECG can you see on P? What can you see with P on ECG? What else apart from S1Q3? Sinus tachycardia. Okay, so inverted T on V1 to V4, yes. So that is. But the T-wave inversion are quite widespread. So it is, V1 to V4, yes, not just T3. Yeah. So are you surprised? Makes sense? Not make sense? Don't know why. I can explain. Now you're thinking, Are these inversion in anterior leads, is it compatible with PE, or you think of something else? Can't rule MI yet? No, you can't. But do you think, but yes, okay. One more thing you can see, okay. And what else one last thing you can probably see in here. One more thing. So we're now thinking of, because of troponin is high, you're thinking at least high risk is at least, pretty big PE, right? So what other changes can you see in big PE? What happens in a big PE? What does it cause the heart? What happens to the heart? Right BBB, right bundle band extra. Yes. So putting strain, right heart strain. Okay. So that's what happens. Anteriorly, you can get right heart strain, and you can get T inversion in anterior leads. Okay. Yes. So the differential, obviously, you can narrow down, and this is probably the full spectrum. You're not going to see all this in a PE, but I've just chosen one which will give you the full gambit. So, but mindful, a quarter of ECG and PE is completely normal. Okay, you don't see nothing. And again, 7% does look like ACS. I agree with you. Okay. But, if you get a full gamut of these things, I think the most common thing you see in PE is actually sinus tachycardia. It's not S1Q3T3. It's fairly specific, but it's not that sensitive, okay? So if you think of PE, the most common ECG you see is just sinus tachycardia. But, if you do see sinus tachycardia, and then now, S1Q3T3, T-wave inversion, anteriorly, RBB strain, you get a full hog. It's going to be, looking at a fairly massive PE. But what I'm telling you is sometimes I show an ECG like this, you'll probably miss it completely. And many people have missed PE a lot of time until afterwards, when you think about PE and you go back and say, hey, he's got everything here. And so, ECG is a lot easier when you have a history and in perspective, then you would know what you're looking for rather than just, look at a blank ECG, because, not everyone will look at S1Q3. But if you have a patient that you're considering PE, then you will look for it. And you're very good. And this is the first thing you pick up. But all these other things you should probably know. So PE is very common, is often missed. Okay. So you should be considering chest pain, short of breath, and even patient with unexplained syncope, because up to 17% of PE present with syncope rather than chest pain and short of breath. They just pass out. Okay. And so you have to think about it. Some unexplained syncope, could be PE. Hemoptysis is actually quite rare. And so patient obviously can collapse because of severe massive PE, and they never make it in the hospital. About a third have signs of DVT, but you may not have that. Okay. And often up to 40% of unexplained tachycardia is due to PE. So if someone just come to you with unexplained tachycardia, think about PE. Okay. And also, suddenly have low oxygen saturation. These are things which make, you think about PE, and it's why so is missed, because it's something that you often think about. Okay. And obviously, risk factor of PE, like our patient had a recent surgery and has been in bed. And then don't forget that patient with cancer, pregnancy, postpartum is also a risk factor of PE. But 40% have no risk factor whatsoever. Okay. So these are that will alert you, but, some people may not have. Okay. Obviously, you have those hereditary factors which you won't know until you check later. Okay, in terms of symptom and signs, shortness of breath is probably the most common, but in terms of signs, patients, tachypnea and tachycardia is probably the most common. Okay, the classic pruritic chest pain, dyspnea, hemoptysis is actually quite rare, and presentation can mimic ACS in a lot of cases. And the severity of symptom really depends on how big the PE is, and your underlying recognition is small PE or massive PE. Okay. So, I won't go into too much detail today. It's more about our approach, but I'll just let you know that the approach to PEs can be quite simple if you think about it. Okay, you think it's high or low probability. You think it's high probability, then you could go to CT angiogram. But be mindful, if the patient is quite severe and in shock, you actually do not need a CDPA to diagnose PE. If patient has very high suspicion, and that's got all your ECG, and the patient in shock, you do not need a CDP or angiogram. You just need to do an echocardiogram and look for any RV dilatation. If you have all these things and you have a severe RV dilatation, then you can probably confirm and almost treat it as massive PE without doing CPA. But you have time, sure, do a CPA. But there are times when you don't, for example, you need to start treatment without wasting time doing CPA. But if you think of the patient very, very low probability, you're just not sure, then, instead of doing, you can do CPA, but, a cheaper way, a fast way, just do a D-dimer. And you can exclude it. If you're low probability, do a D-dimer, you can exclude it, no treatment. But if your D-dimer is positive or, you don't bother doing it, you can do a CPA. But sometimes I'm trying to reduce your reliance on CPA. Because CPA can only look and see large PE. It doesn't exclude small PE whatsoever. Okay? So, you're mindful that CPA is not perfect. Okay, and other option, you have time, you probably think about is look at a VQ scan. It's a bit old-fashioned, but sometimes it's useful. And D-dimer, although it's very sensitive, but it's not very specific because still can go for many other reasons. Okay, and one I think you can also do an arterial blood gas, looking at a large AA gradient. Okay, so let's move on to our second case. So it's Mr. C, 67, with past history of hypertension, diabetes, dyslipidemia, and coronary disease with a PCI a few years ago. Now he presents with new onset of chest pain for about 2 hours. That's retrosternal, 7 out of 10. So nausea and diaphoresis, and he says having a heart attack. So heart rate is 108, blood pressure is a bit borderline, O2 is a bit low. Examination is obviously having chest pain. He's, a bit sweaty. His crackles at both bases, due heart sound. So what are you thinking now? As you're getting more and more information, you start thinking, So do you think he's having a heart attack? He tells you he is. Maybe. Maybe not. You thinking of anything else? Okay, so, based on the history, for the risk factors, you're telling you heart attack, so maybe he's right. It's nothing seems to scream out at you like PE. Dissection is possible. Pneumothorax is unlikely. So you're probably looking at ACS, dissection perhaps. Okay, this is high and differential. So again, same thing, ECG, chest X-ray, troponin, stabilize the patient. Okay, so when you look at ECG, and then you have to sort of deciding on a few things. Is it likely ACS, or it could be something else? Okay, if it's clearly, obviously non-cardiac cause based on ECG, completely normal, it still be ACS. You may require further cardiac testing, or do nothing at all. But you think it's your ACS, then you're sort of using your clinical decision pathway. So you sort of just try to stratify these patients, okay? If it's possible ACS, you obtain your troponin and then decide whether it's high risk, intermediate risk, or low risk. If it's got very high risk features, then you probably go, decide to go more in the more invasive route. But with the low risk features, then you probably, look for more, some sort of testing. So what are the changes in ECG you would likely to see that is suggestive of ACS? It will make you, concerned. What ECG changes to look for in ACS? Elevation, yes. Well, is okay. Depression, elevation, depression, and what else? Inversion, okay, that sort of thing will make you very suspicious, okay? So it's very obvious. If it's elevation, it is STEMI. Well, Q wave is probably Q wave is probably more look at old. It doesn't tell you what happening now, okay? Q wave just shows you that the patient had an MI before. But it's more ischemic. It may, it may be, but not as useful. So obviously, if it's elevation, STEMI, then you go, start treatment. Okay, then you go active cath lab, thrombolysis, or go to cath lab and do primary PCI. And then, you look at these are the changes. If it's depression, or new T-wave version that's new, then you probably follow more the non-escalation ACS sort of pathway. But you have diffuse elevation and sort of consistent pericarditis, and you obviously treat it as pericarditis. And then if it's not diagnostic or normal, then you will repeat it if the symptom persists or change, or if troponin is positive, then you do serial ECGs. Okay, so and if there's arrhythmia, you do that. And it's also important that if you do multiple ECG, because if you do a single ECG, you may actually miss in a very early MI. So in terms of biomarkers, there are things that we need to look for, okay? It's not just looking for an elevated biomarker. You want to see a rising trend and also a falling pattern to confirm, because some people could have persistently high troponin. Some people have a very low elevated troponin and doesn't go up, doesn't go down, and so is not necessarily. So you have to look at multiple enzymes, look at a rising, falling trend. And nowadays, obviously, the high sensitive troponin is the preferred biomarker. Is a lot more sensitive. Elevation is much earlier than a standard troponin, so it's much more, give us more early diagnosis. But again, because so sensitive, you could include a whole lot of other things too. And now CKMB is often, and myoglobin is not useful. And now the latest guideline says like with a class 3, it's like no benefit. Okay, now with troponin, we don't really use CKMB or myoglobin to diagnose MI or in chest pain. Okay. So the difference I mentioned is that high sensitive is more sensitive, okay, than the normal, and it elevates much earlier. If patient have a ischemia, then it probably rise, very early compared to a standard troponin, which goes up much later. Okay, so you can able to detect MI much more earlier at a much lower level. Okay, so if you look at textbook and traditionally, when you do a enzyme in my days, even with troponin or and even my early training, before troponin, I used CK-CKMB that day. You do 6 hourly, so like and up to like 12 hours or even 24 hours of serial blood tests. But now with a high sensitive troponin, because of the early rise, you don't need to wait that long. You have chest pain. If troponin doesn't go up in 3 hours, it's not going to go up. And then now there's some people more aggressive. There's some even 1 hour protocol. But to be more on a conservative side, that a 3 hour is a good rule. That you're not going to miss anything. If you do a troponin in the beginning, if you do troponin 3 hours later, it's not going to go up. It's not going to go up. Okay. So, and you also look at the magnitude of the change. If it's no change, and you probably can, look at something else, discharge, or do some sort of stress test. But if it's elevated, and it's also the magnitude of change, often we're looking at a 2 or 3 fold magnitude increase. The height increase make it more likely. So you jump from say 10 to 100. So this is more specific for ischemia. And mindful that a lot of things can push the troponin up, but everything, all these can push it up, infection, everything. And you also know that the more severe it is, the more high it goes. Like STEMI's got the highest of it, and non-STEMI and all that. But don't forget, even if you run a marathon, your troponin can go up. Okay? But obviously the magnitude of the sampling still is not insignificant. And PE obviously can go up, and a whole lot of other stuff can go up. So mindful is very sensitive, but it's not specific for ischemia, but obviously in a very high level of troponin, becomes more specific for ischemia. Not many things can push the troponin up that high. Okay, so another important concept that you need to be familiar with is how to stratify patients' risk with ACS, because all these are ACS, unstable angina, non-STEMI, and STEMI, and obviously the spectrum of difference of ECGs and troponin, and you risk them into low risk, moderate, high risk, or STEMI. Obviously, STEMI, you just go try to do the treatment. Low risk, you go one pathway. In a medium high risk, you do another pathway. So the risk assessment can determine how you're going to treat these patients. The high risk people, including face angiogram, and in the moderate range, you do some sort of more functional or sort of scans. And also, you want to identify the very, very low risk where you don't do nothing. Okay, don't waste your resources testing them, because just so you have to identify who are the high risk and go to the cath lab, or really the really low risk. then you can just discharge no more testing, and everything between, you do some form of testing. So there okay, so let's move on to the third case. So it's Miss B, is 44, presented with recent onset of chest pain on exertion. Okay, she has family history of chronic disease in the 50s. She's a non-smoker. She's unaware of her diabetic or lipid status. Because often patients say, "Oh, you have diabetes, cholesterol?" No, I don't, but they never checked. The other ask them, "Have you ever been checked before?" Her exercise tolerance is severely limited by her knee injury from skiing, so she can walk very far. And remarkable sinus rhythm and right bundle bench block. Troponin is negative twice. So what are you thinking of now? What are you thinking? And what's your sort of approach to this? What we've talked about before, Now, do you think it's the chest pain sounds like ischemic? You're looking down the more ischemia pathway. And what makes you alert you, and what makes you be worried, and what information can help you, negotiate the pathway we talked about. Young, 44, stable patient, exertional chest pain, so could be stable angina. You think it's stable? Could be angina. You think it's very stable? I should give you like recent onset. So it's new onset. Okay, so the definition is unstable because it's new onset. Okay, so it's undifferentiated new onset chest pain. So what makes you think is more likely to be, as I mentioned, young 44, majority of these pain are not specific, right? But what makes you think that is more likely to be cardiac? Based on what I give you? On exertion, could be a family history, because the family history is very important. 50s are very young. Okay, so that is put me on alert, because everyone with a premature coronary disease put you on alert for everybody else. Okay, so although we don't know the diabetic lipid, she could have undone diabetes, but lipid is sky high. We don't know. But based on the family history, then I would be more concerned about this chest pain. Okay, it's new onset, so it could be unstable. Although the patient, the right bundle could be helpful or unhelpful. Could be new, could be old. We don't know. So, but at least the troponin is negative. So at least we don't think the patient has an MI now. So in terms of ischemia, then she will be in more category, probably in the low intermediate range. At least she's not high risk, right? Because the enzyme's normal. So then what is the next step for her then? Clearly you're not going to send her to the cath lab, but what are you going to do next? Okay, what are you going to do next to further assess her chest pain? What's your approach now? Okay, what are you going to do to diagnose this chest pain? What is your, you've done your physical examination, done history, now you have to do some testing. But a chest pain must be new onset at some point in time, if new onset is a definition. And then, I think, okay, all right, so I'll be, so new, so definition is sort of like skin chest pain, so increasing frequency, but new onset is probably the softest one, yes. Everyone come, but sometimes people may not. People come in and say, I have this chest pain for a long time. So I mean stable angina, you mean the patient has very, predictable symptoms. We don't know yet. Okay, so by definition, I think you're going to if you err on the very side of cautions, then everyone with new onset, never had it before, could be potentially unstable angina. Could be, all right? But in the scheme of things, if it's unstable angina, it could have a very low risk unstable angina. This is probably the lowest spectrum, you would say. So I think new onset means she never had this before, she probably, I can say, new onset, she had this chest pain, over the last 2 weeks. That's still new onset. That's patient never before. So you don't know how it's going to happen. She could be, so by definition, look at unstable angina, the new onset chest pain, is one of it. Okay. So yes, I mean, it's soft, but even it could be beginning of her ACS. Okay, because we don't know what's going to happen to her, say, next week, right? But now she comes to you with a new onset chest pain, undifferentiated. You have to treat it. Think about unstable angina, but it doesn't have any high risk features, so it would be a low risk, unstable. If you can get my meaning. So you're still following that pathway, the ischemic pathway. So how are you going to differentiate? How are you going to decide whether it is or not ischemic chest pain? So I'm not saying everyone with new chest pain is called unstable angina, but if you're thinking of ischemic chest pain as new onset, then you will consider it as unstable. All right. Not everyone with, like, for example, patient with non-severe chest pain is new, but I'm not saying all of them is unstable angina. Okay. All right. But if it's new, never before, then it's not stable until the patient proven that the symptom had a stable pattern. So you can't call it stable angina. She never had it before. There's no stable pattern to it. Okay. So what are you going to do? What are you going to do? What are you not going to do? Well, you done this, so you're going to just stare at the patient? Are you going to do something? Sure, do all that, but that's not going to tell you your blood chest pain. We'll do that. Yes, it will give you more, things to put in perspective. Yes, but it still doesn't explain the chest pain. So you're not going to investigate. Send the patient home. See you later. Do some blood tests. Okay. So is she so low a risk that you would not do anything? All right, because we've sort of said it. She has a family history. We don't know. Okay, we don't know about profile, but based on some family history, and then ECG not entirely normal. The right bundle could be normal, not normal. It's not entirely normal. So I would not put her to the so low a risk that you would not do. So no invasive, agreed, no invasive investigation. Yeah, so I thought you said no investigation. Yes, definitely no investigation. So you lower it, and then you would do something, right? For a patient like this, you would not do nothing. So you would do not invasive, not do nothing, but you do it in between some sort of testing. The question is, what testing are you going to do? Okay, so when you look at a patient, sometimes you mentally calculate some sort of risk profile. I mean, just based on just chest pain, female age group, normally they're fairly low. All right, but because of her family history, you might adjust that a bit higher. So I'm just, I think mentally then, and you sort of give an idea of what the patient's likelihood is. And if you have the diabetic and lipid profile, you'll probably adjust that if he's diabetic suddenly or smoker and then have a very high lipid profile, then the likelihood jumps up. And then therefore you'll, be more keen to do certain tests. So what type? Then the many types of tests you can do, okay? And sometimes the tests that we choose are based on what we think the likelihood of patient having disease. So what type of tests do you know? So in this juncture, you could do exercise stress tests, okay? Stress test is a very broad. So what you actually can order, what other tests can you, at this juncture, you can choose from? What can you choose? All right, being a doctor is to choose. So what other choices do you have? CT, core angiogram, yes, stress test. Okay, so which one are you going to choose? So this will give you the answer here in a way. So you can see here, this is not absolute, but this is one algorithm which the American College is sort of proposing. Is a very, very low risk, you do nothing, but obviously we think this patient is at least some risk. Therefore, she's sort of more low than you favor CT coronary angiogram, but if a little bit more high risk, you can go more stress tests, because a stress test will miss a very minor disease and you could miss things. So it's not absolute, but you can do either one. So how are you going to choose based on this patient? What are you going to choose based on our story here? What are you going to you will favor you doing? Okay. What would you, if you have this patient, what would you actually choose? A stress test? If you stress at what type of stress test? Or would you send the patient to a CT, or you prefer CT angiogram for this patient? So since both of you, so Stephanie and Cho Yun, why would you want to do one or the other? Why wouldn't you one or the other in this patient? So Stephanie, you said exercise stress test. So what are you actually going to order? You're going to exercise, what type of stress test do you know? Stephanie, you said exercise stress test. So which particular one you know? So you put exercise stress, it could mean a few things to different people. What are you going to order? Change your mind. Okay, why? Why do you change your mind? I'm not disagreeing with you, but you want to justify it. You're calling up for CT angiogram, say, look, the waiting list is 2 years. Why would you choose CT angiogram? Why wouldn't you choose stress test? What type of stress test do you know? Yeah, okay, sure. She can't exercise truly because she can't, you got to think about it. And time and again, we see patients stand to stress tests or a treadmill that can't even do the treadmill. Where people were 80 in a four-wheel, prong stick, wheelie frame, walking in a shaking with Parkinson, doesn't work. Okay, so you look at the patient, look at that. You can do a stress test, but you're probably not going to do a treadmill stress test. But you could do other forms of stress test. You can do a stress echo. You can do a pharmacological stress echo. Okay, you can do that. So it's perfectly fine. So Marcus, you can do that. So you can do that. You can do a stress MRI if you want to. You can do a stress nuclear test. You can do that, or you can do a CT angiogram. Okay, so you can do it either way. Okay, I'm not saying one right or wrong answer, but this is the things that would favor one or the other. Okay, so you think her likelihood is maybe you want a younger patient, usually a young patient, what you want to less likely, you want to rule out. And CT angiogram has a very high negative predictive value, so you can rule out. If it's normal, then you rule out. Okay, but you may miss things, but if it's normal, then you can rule out. And also in a younger population, you have to think of some other rarer causes, which such as anomalous coronary artery or certain things which you're not going to see on a stress test. Which anomalous coronary less likely to present elderly, more present in a young population. So, also patient can exercise. Okay, so in this patient, it's more personal that based on many factors. I think I just want to. I put her at some risk because of fancy, but she is young and no other risk factor. I think a low risk, and I just want to exclude coronary disease. Therefore, I would favor CT coronary angiogram. But you can by all means do a or you mentioned stress echo and stress MRI. However, that you have to think about what this test can give you and what it doesn't give you. Okay, so in terms of stress testing, that all types of stress testing. Okay, again, if you have to be able to stress to do this, so for this patient, ETT is out. So you're thinking about the other ones. Okay, and these have added benefit of seeing some other stuff too that you might want to see. Okay, but you need to consider availability, cost, and expertise. Okay, for example, you can do a stress cardiac MRI, expensive, not relevant H.A. So you are being excluded from that. Stress echo is very dependent on expertise. So in this hospital, you are very lucky because we have Professor Lee and Dr. Kam, who's an expert in this. So we've got expertise and give very good stress echo imaging here. But the waiting list is 2 years. So again, not very good because of the availability. Stress maybe is okay in good hands, but unfortunately, don't tell people. Don't say I said this, but in this hospital, they're not so accurate. So based on expertise, I would not do a stress nuclear test in here, But you have to be, that's what you understand in the world, that there are cost, availability, expertise, which might factor in. So CT core angiogram is a bit less expertise dependent. It's because of imaging, it's you get a good image, usually pretty accurate, and usually more available is lower cost. So, in this patient, I would probably use a CT core angiogram. And obviously, it's a huge, things which push you one way or the other. Okay, so not be exhaustive, but you have to think about this. Okay, so in this patient, therefore, I would do a CT or angiogram. But by all means, if you've got availability, you can do a stress, but not exercise stress test, but something else. Okay, all right. So this is how I would approach that patient. How I would choose which test to do. So I think one more case. So you are called to admit a patient 65 to rule out ACS, type 2 diabetes, remote ACS, hypertension presenting with severe abdominal chest pain. It began 3 years ago, subsided slightly, but it's still quite severe. It's a bit different to the MI, it radius to the neck. Right arm's a bit weak. It seems new. Heart rate a bit fast, but pressure is, quite sort of normal, slightly high in the right arm. Heart rate, O2 seems to be okay. Discomfort, it's got left carotid bruit. It's got early diastolic murmur, lung clear. It's got tear inversion similar to before. So what are you thinking now? You've been called to rule out ACS because patient have chest pain, diabetic, has MI before. And based on that, are you considering anything else based on other information? Yes. Why? Why? Right to back? Inside the neck? Inside the back? In right to the back? Right to the neck? Is it useful? Arm weakness. How is that so? Oh, sorry. So does it change you? So it's not back, it's not dissection now? Or you still think dissection? It's to neck. It is still good dissection? Impaired blood flow to the arm causing weakness. No. Why do you think there's a less likely cause for that? So why would you think he has a weakness? But what do you think of the, about the left carotid bruit? Could be impaired blood flow to the arm because it could dissect it to the arm. Sure. But usually, if it's dissected arm, you probably get a weak pulse rather than a weak arm. What do you think of the carotid bruit? Oh, it's carotid thrombus dislodged causing stroke. You think so? What are you thinking? Why do you think patient have carotid thrombus? So you think it's dissection, or you think it's something else now? Why would the patient suddenly have a thrombus in his thing, and what's going to do with the chest pain? How do you put things together? How about other things in the thing? The things that seems to all add up to one thing, or there's some sort of do you think you have two things, or you can have some like unifying thing that what do you think? How do you put it all together? You try to dissect everything, to extract everything you can see here. Can you explain it? If you think of dissection, can you explain everything you see here? No, or just so because when you try to extract information, so don't just focus on just the history, but try to put everything you get and trying to incorporate. That's how you become better clinician. That you're trying to or the other stuff just you're not useful. I'm just giving it to you for fun, or you think that all adds to something? What about the corroboree? What about the early diastolic murmur? Useful, not useful? Yeah? No? No? Just putting it there? Don't add anything to it? Who said dissection before? Who said dissection? So Chuck-Sing, you said dissection before. Okay, can you put everything that would dissection explain everything? 2 new messages. Yes, okay, so you're thinking now. So you have to add things together. You think that's saying you're going to find things that can add to it, okay? Can cause inferior MI, and stroke, of course. You can dissect down, dissect up, and you can cause, down, causing valvular irritation. You can dissect into the coronary and cause an MI. You can, dissect up the neck to cause dissection, to connect dissection. And this has happened. A real patient was admitted to the stroke unit here a few years ago with, right hemiparesis and then hypertensive and then given thrombolysis. Okay, and then the patient crashed, in the ward. And then you do echo, have a tamponade, it was severe dissection. So, because they weren't thinking, patient actually had dissection, and then given thrombolysis, patient died. Okay, so that is an unfortunate case, but you have to think about. All the information you're getting is it useful? Don't just so blink it that you just look at one thing and then just block everything else. Okay, everything else seems to all add up to potentially a dissection, right? So does this chest X-ray help you? So again, when you look at investigation, ECG, chest X-ray, or whatever, think about the patient you're looking at. If you're thinking about dissection, are you seeing anything? Yeah. Okay. So you want things that adds to you, or things that's going to, sort of make it less likely. Okay. So you're obviously suspecting dissection to widen the knob, and it's not always. You can have a normal, meastime that consider dissection, but if it's wide, then it's more likely. Okay. And also, perfusion is another possibility, but it could be complete normal chest X-ray, in about, some patients. Okay. So what you can do next, obviously imaging, and most commonly we do the CD coronary angiogram, CD angiogram. It was the first line. It's very sensitive. So you can often see a dissection plane here pretty clearly, here like that, and here dissection pretty much. But if it's not available, MRI is not so useful. It's more for surveillance, not acutely. We don't really use MRI. It can be used, but we just don't do it. The other thing is that you don't have CT, and I think you can do echocardiogram. And sometimes you can see a dissection in a transophageal echocardiogram in the ascending aorta. If you're very good, you sometimes can see it, but it's not. But you need to be very good at it. Okay, but sometimes you just don't have a CT. You can do echocardiogram and sometimes see that. Okay, and the classic is tearing chest pain from front to back. And then this is not that common. Okay, so yes, a lot of people have chest pain, back pain, more likely in type B rather than type A. You might not get that in type A. Usually a quite acute onset, and if you have aortic regurgitation, it's more like the type A. So all these things can happen. It depends where you dissect. You go down or up, or go up the neck or down the arm or whatever. And also I'll give you just the blood pressure on the right arm. So if you're very astute, you should say, I should have done blood pressure on the other arm. See whether there's any difference in the two arms, right? I just gave you one arm. Okay. So again, if you're thinking, you will do more. Not thinking, you just take it as it is. Okay. So you have to keep thinking and saying, what am you doing? Okay. ECG can mimic ACS, and typically, I don't know why it does it downward. It often goes to the right cusp and cause right coronary artery dissection and cause inferior MI. And again, it's my own patient, acute MI, RCA MI, and then we angiogrammed, and then we thought it was, and then the right kind looks a bit occluded, but it looks a bit weird. We put a balloon pump up in the patients, and without knowing it, I put a balloon pump in the patient dissection plane and actually pumping into that plane and causing massive extension of the dissection. So, we were not thinking at all, so it can happen. Okay, so luckily the patient survived. But the ECG can mimic, especially inferior MI. Okay, so this is 4 cases. Just a quick few quizzes, and we'll call it a day. Just to throw in a few ECGs. So very quick, try to be rapid fire because I'm running out of time. Okay, so the ECG, it's a STEMI or non-STEMI? Chest pain. And if it's non-STEMI, what are you thinking of? If you're not going to answer, right, then I'm just going to stop this tutorial. There's not much point me just keep yakking on. Okay, if you participate, I'll keep going. If you're not, I will just stop. Okay, what are you thinking? STEMI or non-STEMI? Human version. What are you thinking? Rapid. Come on, hurry up. Okay, Welland syndrome. Okay, very good. So what does it mean? There's a guy called Welland who notices everyone with ECG like that sort of dies quickly. Why? It could be biphasic inflammation anteriorly, is a high risk ACS. Sort of usually is a significance approximately. This patient can't go home, need to angiography ASAP. Not straight away like a STEMI, but should be done as early as possible. You just have to tell the patient, I've got a patient ACS with sort of Welland ECG, and then people will alert and will treat it more aggressively. All right. So this is the second one. Quickly, out of hospital cardiac arrest and cardiogenic shock. STEMI or non-STEMI? What is going on? What do you see? Okay, 1 minute. Okay, elevation AVR. What else? What else do you see? With diffuse abrasion. So left meniscus. Okay. Bang, straight on. Okay, left mechanical closure. People don't look at this sort of thing, all right? But if you look, you see, firstly is widespread ST depression, ST elevation, AVR, patient cardiac shock, stress, thinking about left main occlusion. Okay, this one, STEMI or non-STEMI? Good. Okay. Okay. So you still see this change, look depression, but if you want to, this is actually posterior MI. So this is what I call the flip. You just turn the ECG upside down, back to front, and look from behind the paper forward, and you'll definitely notice you flip around and you get elevation anteriorly. So you just did a very quick, cheap posteriorly ECG by flipping the ECG around. Okay, so this missed every few months. That patient will get rolled into in the cath lab saying patient at high risk non-STEMI ST depression turned out to be a posterior MI that's missed. So this happens all the time. We see it every few months. And the patient they actually missed the posterior MI. So try not to be one of those. Okay. Okay, you can do posterior leads if you want, but we rarely do it. You can just flip it. You don't need to put any leads in the back. Just flip the ECG around. If you don't know how to do it, you can ask somebody to explain to you and show you how you flip the ECG around. Okay, this one, what is it? STEMI or not STEMI? My other things. What do you think? You're on a roll. Going to keep going, or you get all three right. You can come and claim a prize. In the old days, when I actually give, lecture in the theater, I usually give out prizes for every question I ask all along. I get gummy bears, but unfortunately, I can't throw you gummy bears across a Zoom. So, you might have to claim it from me later. But, that seems to work. Gummy bears seems to be quite effective in getting you guys to answer questions. What do you think? Anybody? If you guys see 7-minute elevation, what is it? You're on a roll. Yes? Any specific? Pericarditis. So what do we think pericarditis? What are the features of pericarditis? Go on. Okay, why all the question marks? Don't be so doubtful yourself. Is global. Anything else? Is what's the sort of features? I'll give you nothing, no history. You see. Okay. And PR depression, good. Concave. All right, you got it all. Okay. So diffuse concave upward as depression in most leads and PR depression in most leads. Okay. So you can convince yourself, and therefore you don't need the question mark. You can just say, be fairly convincingly, this is what I'm thinking, without even knowing the story. Okay. So the take-home message is acute chest pain is a very common presentation, one of the most common you will ever see. Differential is pretty wide, but you must not miss the life-threatening course. And by not missing is by thinking about it every time you see someone with chest pain. Okay, and then have a very high clinical suspicion, especially it's for acute for ischemia, especially in women and elderly because they present atypically. Okay, good history taking, for examination, and targeted investigation, lead diagnosis in most cases. Okay, and also think about not just doing overcalling, doing to everybody. You think about if chest pain is a very low risk. You think about you don't need to do any urgent diagnostic testing. You can probably send the patient home and maybe do some elective sort of testing. So you want to be able to not just diagnose it and also actually stratify how urgently you need to do what you want to do. Because sometimes the test may not be available. Sometimes for a long time, you have to decide, can the patient wait or not? Okay, so thank you. And chest pain, think about emergencies, and then you can work out the rest later. All right. Any questions? If not, I'm going to outpatient. Are any of you going to outpatients? Hypertension clinic? Or no? Nobody? Somebody? Any questions? If not, I have to go to clinic. So if there are no questions, thank you very much. Bye-bye.